Thank you very much. It's always a great pleasure to come and talk to nurses who really play such a vital role in the whole area of screening to prevent cervical cancer. Before I start, I too would like to pay my respects to the traditional owners of the land and to the elders, both past and present. So I'm going to talk to you in brief about the future of the cervical screening program, or Renewal. Big thing, no more glass slides. Very exciting. This time next year, that's what we'll be doing. So we won't be using glass slides anymore. It'll be very, very exciting. I'm from Victorian Cytology Service, and I just thought, to begin with, I'd actually tell you a little bit about VCS. But let me just start actually by quickly going through my objectives of my talk today. And that is for you to have a clear understanding of the role that HPV plays in the cause of cervical cancer. It is absolutely crucial to understand what we'll be doing for Renewal, that you understand what HPV is all about, human papillomavirus. I'm going to talk to you a little bit about the role of HPV testing, why we're going to be moving to HPV testing rather than doing a Pap smear as our primary test. And then I'm going to give you a bit of an introduction to Renewal. Now, keep in mind that we're not all the way there yet with Renewal. Just the draft guidelines have gone out. I can't go into intricate details of Renewal, but I'll be able to give you some broad outlines that you'll be able to take back to the communities that you work with. And then Joe's going to get up and give you a few case examples just to illustrate some of the points that I've been making. So I work with, and have for the last more than 25 years, worked with Victorian Cytology Service. This is VCS, which is in Carlton in Melbourne, up near Melbourne University. It's actually mainly a car park, but we occupy the first couple of floors here. And we also have a site in East Melbourne as well, which is where we run our registry, our three registries from. And I'm ashamed to say that, well, just so that you know, I do walk to work every morning. I'm ashamed to say this photo is actually taken from my front door. So I'm very, very lucky. So just a bit about VCS Pathology so that, you know, some of you from Victoria will know what VCS is about, but just a little bit of background. So VCS is actually VCS Pathology, in other words, the laboratory that does the test. So we were the first laboratory to do Pap tests in Victoria when Pap tests were first introduced in 1965, and then from around about 1980 we've been responsible for doing about 50% of the Pap tests in Victoria, which still means we do over 300,000 Pap tests every year. Phenomenal amount of experience that we've got. But of course we also do HPV testing, we also do histology from when somebody has a colposcopy and has a biopsy. We also do histology from if you need a vaginal or vulval or even a penile biopsy. We also do chlamydia testing on both men and women as well. So we do a variety of tests as part of our pathology service. And of course, I should have said to begin with that we are government funded. We give lots and lots of talks, and we often get asked, oh, are you going to bring lunch? Will you bring lunch today when you give a talk? And we say, well, we'd love to, but actually we're paid for by the taxpayer. It's you and I are paying for this, and we're not a drug company, and I'm afraid, no, we don't bring lunch, but we'll give you free education. We run the Victorian Cervical Cytology Registry, and of course, actually I shouldn't say of course, some of you won't realise this, but we also run the South Australian Cervical Registry as well, but we run the National HPV Vaccine Registry. So we have a really quite a wide role that we play. Now, just to put things into perspective a bit, and many of you, I'm sorry if I'm preaching to the converted here, many of you will already know this, but for those of you who might not, just to put things into context for you, we have a fantastically exciting and successful cervical screening program in Australia. Really, I will say, I think it's probably the best in the world. It really is absolutely fantastic. We certainly have among about the second or third lowest incidence of cervical cancer in the world and the lowest mortality rate in the world. It's been wonderfully successful. We established now in Victoria, we set up a Pap Test registry in 1989, and as you know, there are now registries in every state and territory. So when you or a woman that you see if you have a Pap Test taken, your results go onto the registry, and of course that gives us a fantastic amount of invaluable information that we can use for planning for the future for the Pap Test screening program. We introduced the National Cervical Screening Program in 1991. You know, I was practicing well before that, and I can tell you there was no program before that. When did you do a Pap Test? You did a Pap Test when you thought about it, or when the woman came in and said, I'd like to have a Pap Test, please. It was really a bit of a dog's breakfast. In fact, more commonly than not, you did a Pap Test when you put a speculum in for something else. And you thought, oh gosh, while I'm here, why don't I do a Pap Test? You know, there was no organised program. So we have set up an organised program. Guidelines, the first set of guidelines telling us what to do if a woman had an abnormal Pap Test result, were introduced in 1994. And then they were updated in 2005. And of course now that's what we're updating at this point. We were the first country in the world to put the HPV vaccination onto the National Immunisation Program. We should be incredibly proud of this achievement. And indeed, we were the first country in the world, and we're still only one of about 3, to introduce onto the national immunisation the HPV vaccination for boys. This is fantastic. This is really, really marvellous news. And of course, the consequence has been that really we've had a halving in the incidence of cervical cancer since introduction of the program, since 1991. And it's been, as I said, a phenomenally successful public health screening program. But we still see around about 600 cases of cervical cancer every year, and there are still 150 or so deaths from cervical cancer every year. But as I said, it's been a very successful program. There is, of course, a flip side to this, and Sandy's already alluded to this, and that there is a not-so-lucky country as well, where we know that almost certainly due to poor access and under-screening, that our Aboriginal and Torres Strait Islander women actually have an incidence of cervical cancer, as Sandy's already shown you, at least twice that of non-Indigenous women, and a mortality rate probably up to 5 times higher than that of non-Indigenous women. So we must keep that in mind as well. Now, I always think that George Papanicolaou, after whom, of course, the test is named, the Pap Test or the Pap smear, is a very unsung hero. He first described the technique of looking at a Pap test, of taking a sample from the cervix in 1928. This was then refined in the 1940s and then introduced as a screening test in the 1960s. And really, the introduction of that test has saved probably millions of lives. But I'll just remind you, it was first described in 1928, so perhaps it's time for us to be moving forward again. I should warn you, I'm about to show a few clinical pictures, so I hope that's okay. But you'll, and I understand that also there's a mixed group of you here, that some of you will be Pap nurse providers and do Pap tests, and others of you won't be, but I think it's still terribly important for you to know this information. So of course we're all aware of the fact that when we do a Pap test, what we need to do is we need to put in a speculum. Jump over that one quite so quickly. We put in the speculum, and then when we open it up, if we're lucky, we get this nice clear picture
again,
that looks like
this.
this.
Make sure that you offer Beth some privacy with a sheet to cover herself. Make sure you've got a good light.
Don't know where that's coming. I thought there was an overall announcement.
Gloves.
I don't know. I'm not saying that. I don't know where that's coming from. That's actually me talking. I'll skip on quickly. I had no idea that was there. So there we are. This is. I think that must be taken from our video, which is on the VCS website. So there we are. I was describing. Didn't know where that was coming from. But there we are. We found the cervix. Let's jump on. And of course, we take a sample from the cervix. I know this is an old slide because here's a wooden spatula. We don't use wood anymore, we use plastic, of course. Variety of different instruments, and there is a sheet on the table, the cervical sampling sheet that is a reminder about the different instruments that you use to take an adequate Pap test. So do take one of those with you, or again, you can find that on the VCS website. So we take a sample from the cervix, trying to sample the squamo-columnar junction, okay, and then we take a sample from the endocervix as well. And there's your sheet that you've got on the tables. Do feel welcome to take one with you. And of course, what we're trying to do is we're trying to sample the transformation zone, which is the area where squamous cell cancer arises. And I'll come back to that in a minute, because this is just one of two main types of cervical cancer, squamous cell cancer. So squamous cell cancer arises where the thick-layered cells of the vagina, the squamous epithelium here, meet the thin, single-layered cells as you go up into the cervix, into the endocervical canal. And these cells are changing from one type to another. They're changing or metaplasing. And at this area here, this is called the transformation zone, where you've got transformation of cells. And these cells are particularly susceptible to infection with the virus, human papillomavirus. And when we take a Pap test, what we're trying to do is we're trying to sample those cells, and then we're going to look for changes caused by the virus itself. So we put our sample, we've taken a sample and we put the sample onto a glass slide. And you can see, by the way, from these glass slides itself, what a variation there can be. Can you see how thick this one here is, and how there are very little cells on this one? And essentially, though, let me remind you that when you put your cell sample onto this glass slide, that you put about 300,000 cells onto that glass slide. The scientists will spend about 6 minutes on average looking at those 300 cells, sometimes for just half a dozen cells that might look abnormal. To me, it's always a miracle that they find anything at all. But of course, they're highly skilled, and they do. And we have a program with very high standards, very obviously. But gosh, you know, what a job. The pressure is really on. So I'm not a cytologist, but these are the cells that will be seen, the cells with their nucleus. And this is an example of some normal cells. And what the cytologist is actually looking for is they can't see the virus down the microscope. So they can't see HPV down the microscope. So what they're looking for, they've been trained to look for cell changes associated with infection with HPV. It can be a bit hit and miss, you can imagine. I mean, they're going to say, okay, look, you know, the edge here is a bit more pronounced than normal, and the nucleus is a bit bigger, and there might be what they call a bit of nuclear, a halo around the nucleus. These are the criteria that they're very skilled at looking for, but it's not absolute, which is why when you get a Pap test result back, it should say something like changes consistent with HPV infection. It won't say HPV infection is actually there. So they're looking for those changes, and they're particularly interested in looking for cell changes that might indicate a high-grade change. In other words, when there have been cells that have been infected with certain types of HPV that have been there for many years, okay, not just infected 1 month, cleared the next, but they've been there for many years. And then they're looking for these sorts of cell changes that they're going to report as a high-grade lesion. Of course, every now and again with a Pap test, you get something that you can't read at all. It's just you saw those glass slides before, and you can't make anything of this. Too many inflammatory cells there, it's going to be unsatisfactory. Nobody's fault, not the fault of the person who took the smear, not the fault of the cytologist, not the fault of the woman. Just can't read anything here. You're just going to have to repeat that. So this is all to help you keep in mind where we're moving towards. So let me remind you that cancer of the cervix is caused by human papillomavirus, particular strains of human papillomavirus. I mentioned before that what we're trying to do when we do a Pap test is we're trying to sample the transformation zone, those cells that are very, very vulnerable to infection with HPV, looking for early changes of squamous cell cancer. But there's another type of cervical cancer as well. There's adenocarcinoma. Adenocarcinoma occurs higher in the canal and deeper in the canal. And the Pap test has never been any good at finding changes of adenocarcinoma. So if changes are found on a Pap test, it happens every now and again, but it's through sheer luck, believe you me. What tends to happen with women with adenocarcinoma is that they tend to they may well have had Pap tests that they've had for many years that have always been negative, and then they present to their nurse practitioner or to their GP with some bleeding, and even then they might not see anything on a Pap test. I remember seeing a GP quite a few years ago who said to me, "But Stella, look, I've got this 42-year-old woman. She's been a patient of mine for years. I've been doing her Pap test regularly for years. They've always been negative." And then she presented to me with 2 or 3 episodes of postcoital bleeding. I did a Pap test that was negative. I did a screen for STIs. All the tests were negative, but I was worried about her, so I referred her for a colposcopy, and she had an adenocarcinoma. Now, what I want to remind you, and believe you me, doctors do not know this. I'm always fascinated by the fact they don't know this. In my teaching of registrars, I always say to them, what causes squamous cell cancer? And they're very good. They know now. They say HPV. And I say, yeah, can you tell me just a little bit more? What types of HPV? They're very good. They say HPV type 16 and 18 mainly. I say, terrific. And then I say, well, what causes adenocarcinoma? And there's usually a deathly silence. Somebody said the other day, oh, is it chronic inflammation? Somebody said, is it smoking? Someone said, is it related to bowel cancer? And actually, I'm actually often pleased when they get the question wrong, because I'm always then hopeful that they're going to remember the right answer. And of course, the right answer is it's HPV. HPV causes adenocarcinoma. Keep in mind that probably over 99% of cases of cervical cancer are caused by HPV, and the incredibly rare ones that don't have the sort of cell changes that would be picked up on a Pap test anyway. I've just shown you that what you're looking for when you look for cell changes is you're looking for changes associated with HPV. So if you've got an incredibly rare cancer not caused by HPV, it's not going to be seen on a Pap test anyway. So again, those women are going to be women who would tend to present with symptoms. So cancer of the cervix, both squamous and adeno, caused by HPV. And we can prevent, you can never with a screening program prevent 100%, but we think we can do pretty well both by vaccination and by screening. So a quick reminder, HPV, human papillomavirus, over 100 different types. And the fascinating thing about HPV is that different types infect different types of the body. So you've got certain types that will give you warts on your hands that most of us had when we were children. Certain types that will cause papilloma on the feet. Quite different types to the 40 or 50 types that are found in the genital area. I don't know. No one knows. Why do they just infect the genital and the oropharyngeal area? I don't know. Just a quirky nature of those types of HPV. Those HPV types are spread through skin-to-skin contact, microabrasions in the skin, highly infectious and very readily transmitted. The common cold of sexual activity. Have sex, you will almost invariably get HPV. Actually, most of the time, you get rid of it as well. It's like getting a cold. If you mix with a whole group of people like we're doing today, you're going to get a cold at some stage or other. It's unlikely that many of you would go on to get a pneumonia. Somebody might, but most people will clear the virus, often clear the virus quite quickly. you've got around 14 of these 40 or 50 types that are what we call the high-risk types. We also call them the oncogenic types. In other words, they've got the potential to cause cervical cancer. Now, another important thing for you to remember, being infected with one of the oncogenic types does not mean that someone's going to get cervical cancer, but you've got to be infected with one of the oncogenic types to get cervical cancer, okay? And that's important because when ultimately you're explaining infection to women who have HPV, then it is important, I think, to be able to remind them that most of it goes away. Even those oncogenic types, most of it will be cleared. We've already mentioned a few times that types 16 and 18 are indeed the most important types. And it's because, in fact, types 16 and 18, two of the 14 oncogenic types, cause around about 70% of cervical cancer internationally. In Australia, about 80%. So the other 20 or 30% is also caused by HPV types, but by the other 12 or so of those oncogenic types. Now, can you understand from this, by the way, why, even if you've had the vaccine, you can still get an abnormal Pap test? Because even if you've had the vaccine, you've got another, another at least 46 types that you can be infected with. And a lot of people don't understand that. Even highly specialized people don't understand that. Lots of other types that you can be infected with. In passing, many of you will know this, but type 6 and 11 are not oncogenic. But they're included in the vaccine because they cause genital warts, 95% of genital warts. And for those of us, I'm a sexual health physician, and for those of us who for 30 years or so, genital warts were our bread and butter, and they caused a lot of misery. They are very unpleasant, they're difficult to treat, they don't cause cancer, but the world is a better place without them, I'm sure, okay? And we've been pretty successful in actually really decreasing the incidence and prevalence of genital warts now that we're vaccinating our young people against type 6 and 11. This is quite an important slide for you to understand, in particular the timelines. So I've called this normal, but I probably should say uninfected cervix. If somebody has an uninfected cervix and they're infected with HPV, and as I said, that's going to be very, very common, okay? So if they get infected with HPV, in fact, the majority of it goes away. 80% of HPV will be cleared in a period of 12 months. So it takes a while. HPV is very interesting because, you see, as I said before, it's transmitted through microabrasions in the skin, but it just stays in the epithelium. It doesn't get into the bloodstream. It doesn't cause a viremia. So if somebody gets infected with HPV, they don't get those flu-like symptoms of a headache and muscle aches and pains. It just stays in the epithelium. It's very, very crafty. By just staying in the epithelium, it means it's not presenting itself very well to the immune system. So with natural infection, you get a very sluggish immune response, which is why it can take 12 months or so for the virus to clear, which is why when you're treating genital warts, it takes so long to clear them, because you're trying to get the immune system to crank up and produce antibodies and fight against this virus, and it just takes a long time. Instead, what HPV does is it gets into the basal cells in the epithelium, and in the basal cells it gets into the nucleus. And when it gets into the nucleus, it usually sits side by side next to the nucleus. And it's very cunning, because then what it does is it actually utilizes the cell's mechanisms as the cell matures and differentiates, and in fact, when it uses those mechanisms for its own reassembly, and then when the cells are shed, exfoliated, when we take them to take a Pap test, the virus particles are released at that time. Now, what happens very uncommonly, and it has to be with one of those 14 high-risk types, but what happens very, very occasionally is that instead of sitting side by side next to the nucleus, the virus breaks and it inserts itself into the host cell DNA. And when it does that, we call that integrated infection. An integrated infection is much more likely to become persistent infection, to become infection that you don't easily get rid of, rather than getting rid of it in 12 months. Why does it happen in some women? We don't really know. The only factor that we do know of is smoking. So once again, if you can help your patients to give up smoking, you're doing them a great favour. But we don't know why. Why does this happen in some women and not happen in others? But that's what we're really interested in. Most of it is going to go away. If it becomes integrated and becomes persistent, then, and this is a key thing for you to note, over a period of 7 to 10 years, so not tomorrow, but over 7 to 10 years, it can cause enough cell changes such that we might be able to pick it up on a Pap test. Okay? So it's got to cause those cell changes, but I, like many of you in this room, have done thousands of Pap tests. I know what it's like. I know what it's like. It's not like what I just showed you before. You don't just put the speculum in and open it and there's the cervix. More often than not, the anterior wall is hanging down and it's all dark and you haven't got a good light and you're hoping you see the cervix and you hope you sample the transformation zone and you hope that on the day you take your smear, the woman is shedding the cells you want, and you hope she's shedding enough cells, and it takes about 7 to 10 years for her to develop enough cells, and you hope you put those cells onto your glass slide, and you hope that of those 300,000 cells in the 6 minutes that the scientist has, that the scientist will see them, it's a bit hit and miss. It's done us very well, but it's a bit hit and miss. And this is where we think we can do better. By the way, even if somebody does develop a high-grade lesion, it's not an inevitability that that person's going to get cancer. It usually takes another 7 to 10 years to develop into cancer. Okay? And in fact, it happens in about 20 to 30%. So again, about 70 to 80% of women, even with a high-grade lesion, actually do manage to clear the virus. So with all that in mind, and as I said, we've had a very successful program. You know what the Pap test is looking for now, those HPV changes. You know that HPV causes cancer of the cervix. You know that in order for it to cause cancer of the cervix, it's got to be integrated into the cell and it's got to be there for several years. Why do we need renewal? Why do we need renewal? This dates me. It's time. Oh, look, that all of you are so young, you don't know what I'm talking about. I can see Jo wasn't even born then. She doesn't know what I'm talking about. But for those of us of a certain age, we know what I'm talking about. It's time. It's time for a change. Okay. 1972, by the way, Gough Whitlam, but that's a history lesson. Okay. Why? Why is it time? Well, the last guidelines were actually 2005. So it is about time that we updated these guidelines. We've had terrific, 50-60% decline in squamous cell cancer. It's actually got a bit flat recently. We're not getting down any further. Okay? It's just plateaued a bit. We haven't had any change in adenocarcinoma. Adenocarcinoma has remained flat. As we've decreased squamous cell cancer, the proportion of adenocarcinoma has increased. So it used to be, when I first started in this job, it used to be that, 5 to 10% of cervical cancers were adenocarcinomas. But in fact, nowadays it's about 25% because we've been very good at bringing squamous cell cancers down. No good at adenocarcinomas, okay? So that hasn't helped much. We've got a lot of new knowledge about the natural history of HPV, everything that I've just told you in the last 20 minutes or so, and cervical cancer. We've got new tests that are available, our liquid-based tests, and our very good HPV testing, okay? And of course, we've now got a national vaccination program that we've had in effect for 9 years or so, and that's very important as well. So, what are the main features of renewal? What are the main changes that you're going to see from the 1st of May next year? Well, the first thing is that we're going to start screening at the age of 25. Some of you might be a bit uncomfortable about this, and I'm very happy to answer questions about this, but in fact, this has been the international recommendation for many years. And in fact, for a whole variety of reasons, we feel that it's going to be much better to start screening at 25. To be honest with you, screening has never really worked for women under 25. And we've really felt that we've probably done more harm than good by screening those younger women who will have a lot of HPV infection, most of which will actually be transient. So we'll start at 25. We will use an HPV test as our primary test. So instead of looking for the end result of HPV infection, what we're going to do now is we're going to look right at the beginning, and we're going to look for the cause of cervical cancer and hopefully stop any major changes before they occur. We will do testing every 5 years for reasons that I'll show you in just a second. And we won't be doing it in a glass slide. We'll be doing it in a liquid-based sample. We will be doing what's called partial HPV genotyping, which really essentially means we'll just be looking for those 14 high-risk types, but we will be sometimes identifying types, in particular 16 and 18. So we'll be looking for 16. You'll get results of type 16 and or type 18, and then the other high-risk types. And again, I'll explain that to you in a second. We're going to extend the screening program so that we'll have an exit test between 70 to 74. And self-collection of an HPV sample will be available for women over the age of 30 who are under or who have never been screened as well. So why are we moving to HPV testing? Well, we know, in fact, that it's much more effective than cytology. Okay, I'll say once again, cytology is looking for the end result of infection with HPV, and it's done as well, but it's rather a blunt instrument. We know that the negative protective value, I'll show you this in just a second, is much better, and that the positive predictive value is better in terms of saying, well, now if we've got someone who is HPV positive, in particular if they're HPV 16 or 18 positive, we can get in right at the beginning of that person's infection. They may well clear it, but if they develop something, we'll be there much earlier to be able to treat lesions. And it's anticipating that this will result in at least a 20% reduction in incidence and mortality from cervical cancer in comparison to the other program. Now, I'm close to the end of my talk, and I don't often show graphs, but I'm going to show you two, so just bear with me, because they are fairly important. And this is an important one in terms of my desire to persuade you that the HPV test is safer than cytology. And you're going to get lots of questions from this. I can imagine it now. Women are going to say, why is the government doing this? Is it because they want to save money? You know, why are we suddenly, I'm not happy with having a test every 5 years. So let's just have a look at this. Now, this is taken from a European cohort study of many thousands of women from countries in Europe that are very similar to Australia. And what we're looking at is, along this vertical axis here, we're looking at proven incidence. They've had a biopsy to show that they've got a CIN3 plus, a high-grade lesion. Here's time along the horizontal axis. This blue line represents women who have just had a Pap test. This red line in the middle represents women who have just had an HPV test, and the green line represents women who have had both HPV and a Pap test. Essentially, this slide is showing what these tests miss. So let's have a look. Let's say that Sandy did, this is quoted per 10,000, but I'm going to quote it per 1,000. Let's say Sandy did 1,000 Pap tests 2 years ago. She probably did, okay? So she did 1,000 Pap tests 2 years ago, and she's bringing, and they're all negative, and she's bringing those 1,000 women back this year, and she's going to do those 1,000 tests again. Let's see what she'll find when she repeats it. Okay, she'll find that 4, because this is 40 per 10,000, so 4 of those 1,000 women who 2 years ago had a negative Pap test, this year, 4 of them will actually be found to have a high-grade lesion, a proven high-grade lesion. it's not surprising, 4 out of 1,000, because as I've already told you, it's a blunt instrument. Things get missed. You don't always pick the cells up on the day. They don't always get seen under the microscope. So 4 per 1,000. By the way, let's say they're all a bit slack and they don't come back for 3 years. So she sees them at 3 years. What would she find? 5 in that 1,000, which actually shows you that there's not really any difference between 2 and 3 yearly screening. We've always known that, but that's another story. Now, let's say Jo in her practice this year decides to do 1,000 HPV tests that happen to all be negative. And she tells those women, as we will say, for under renewal, she'll say, come back in 5 years. But they don't. They don't come back in 5 years. They come back in 6 years. So they've left it for a year. They come back in 6 years. Here you can see that at 72 months, the incidence of a high-grade lesion in her 1,000 women is lower at 6 years than it was for Sandy's patients at 2 years. And this makes sense because what we're looking for now is, instead of waiting for years and years and years and just missing every now and again those HPV effects on a Pap test, now we're going directly with an exquisitely sensitive test and we're looking for the virus. And when we see the virus, we're going to send someone off for colposcopy, as you'll see, if they've got type 16 or 18. So it's actually much safer. Having an HPV test every 5 years is much safer than having a Pap test every 2 years. The other graph that I quickly want to show you illustrates the difference between 16, 18 and that other group of high risk. So the 14 high risk types, 16 and 18, and then the other 12 types. And in brief, if you were to take, here we've got, again, cumulative incidence of a high-grade lesion, and here we've got time here. And if you were to take 100 women today infected with type 16, don't do anything with them, have a look at them again in 10 years' time, which is what this shows, then you'd find that close to 20, about 18 of those 100 women would have a high-grade lesion. If you took 100 women with type 18 and looked at them in 2 years, it'd be more like 14 or 15, so fewer, okay. Now take 100 women with one of the other high-risk types, not 16, 18, and look at them in 10 years' time, and it's about 3. So in other words, that other group is a much lower high-risk type than type 16 or 18. And this is going to be reflected in what we do under renewal. So how will you do a cervical screening test from May 2017? Well, you'll still be finding the cervix and you'll still be taking your sample, not with a wooden spatula, but in fact of course with plastic. Whatever instruments you decide to use, you'll still be doing that, but you won't be putting it onto a glass slide. You'll just be rinsing your instruments into the fluid. And the fluid will then be sent off. And we'll do HPV testing. And if it's negative, we'll say, come back in 5 years. If it's positive for type 16 or 18, we will do co-testing. Jo will talk a bit about this. We'll do reflex cytology. You won't need to bring someone back, because obviously we can make a smear from that liquid that you sent in. So if they're type 16 or 18 positive, we'll do cytology and we'll refer them. They'll all be referred for colposcopy. If they've got one of the other high-risk types, the lower high-risk types, where you had the 100 women where 3 in 10 years would develop a high-grade lesion, then many of those women will clear their virus. So we'll do reflex cytology again. If it's negative or if there are some low-grade changes, we'll say repeat in 12 months. Let's give that woman a chance to clear her virus. Obviously, if there are some high-grade changes there, we'll say go to colposcopy. If you do see someone who, say you've seen a 24-year-old woman who's had a low-grade lesion, then if her HPV test is negative in renewal, we'll just say come back in 5 years' time. But if she's HPV positive for any type, that's like having 2 low grades in a row, so we'll say go to colposcopy. So to finish, reminders, it is certain high-risk types of HPV, in particular type 16 and 18, that cause cervical cancer, both squamous and adeno. You need persistent infection. Most infection, even with 16 and 18, will be cleared. Please keep screening women, even now, even while we're waiting this next 12 months. In fact, particularly while we're waiting for this next 12 months. We must keep screening women because we know that women who get cervical cancer are those women who don't get screened or are very poorly screened. And an important message for that younger age group of women, those 25 to 35, that 25 to 35 age group, who may well have had the vaccination, they still need to be screened because they're only being protected against 16 and 18, those oncogenic types. There are still the other 12 oncogenic types, and we're a bit worried that message isn't getting across. So Renewal is due 1st of May next year. We'll be doing 5-year intervals with HPV testing, and that's safer than 2 or 3 yearly intervals with conventional cytology. For any Victorian or indeed South Australian nurses, I should say as well, please join us at VCS for Compass, which is a huge, big trial that we're doing at the moment, which is helping to inform the new guidelines and is a way actually of getting 2/3 of women who are enrolled into having an HPV test available now, and will get you and your practices very, very, very up to score with what Renewal is going to be about, such that when the 1st of May comes around next year and the rest of Australia's squirming a bit, thinking, what am I doing and what's going on, you'll shrug your shoulders and say, we've been doing it on Compass, no problem at all. And all of you in here, wherever you practice, please, it doesn't matter if it's Queensland or Northern Territory or Western Australia, please feel welcome to ring us at VCS on that number. There are 6 liaison physicians. And if you've got any queries or questions, not just about Renewal, but anything to do with cervical screening program, at which point I'll hand over to Joe.